All right. Okay, so I see people are joining. We're just going to take a minute and let some other people join before we get started.
Great. Thanks, Alicia.
All right. So I do see people still joining, but I do need to go over some housekeeping stuff. So we'll do all the boring stuff right now while people are still logging on. So first of all, welcome everybody to this week's virtual meetup. We are calling it a town hall, which is really exciting. We're going to be discussing epilepsy and the COVID-19 vaccines. I'm just going to go over some housekeeping stuff, and then actually Barry Goodall, who's with us tonight, I'm going to turn it over to him because he's actually going to be our moderator. So you'll hear from him and how tonight's call will go in just a second. But like I said, some housekeeping items to start. So we are recording this, so just please be aware of that. You can find this recording on our website by early next week. John, I'm going to have you do your usual typing in of the website, please. He's going to type the website and an email in the chat section, and you can use connect@epilepsywisconsin.org for any questions that we don't have time for tonight, possibly, or if you think of something after the fact, you can use that email and we can get the answers to you. If you're an attendee on this call, just know that you are muted and your video is also off. But like I said, please use that Q&A button to ask questions. We will have time for your questions at the end once we are done with our panelists. I think that's all the housekeeping stuff, so I'll just say a quick hello. My name is Alicia Thompson. I'm the program manager for the foundation. We also have John with us tonight.
Good evening, everybody. My name is John. I work with Alicia at the foundation. I work mostly with communications and client support services.
Wonderful. Thanks, John. And Barry, I'm going to turn it over to you for tonight.
Well, thank you, Alicia. Thanks, John. And welcome, everybody. So we're going to do something a little bit different tonight than, for those of you who are regular attendees of our virtual meetups. Usually we have a formal presentation and then leave time for Q&A. So I thought we'd do something different. And I want to talk about COVID-19 and epilepsy. And specifically, we're going to try to bore down and get some information about the vaccines and what patients with epilepsy and frankly, those people who are caring for patients with epilepsy or other neurologic disorders really need to know to help them make the best decisions that they can. So I am really lucky because there's no way I can do this by myself. So I have three of my colleagues, so I'm going to very briefly introduce, and then we're going to start off with some question and answers. Now, one thing that I really hope that people out there will do, what we're going to try to do is I'm going to be posing some discussion questions that things that we've heard from our patients and from other folks about this virus and what it can do in epilepsy and what these vaccines are and what they're not and all these questions, and hopefully address some of your concerns. But I want to hear from you guys. So for people that are out there, if you have questions, please type them in the chat. And I think John and or Alicia will be monitoring the chat, and because I'm really bad at being able to look at the chat box and be able to look at the screen. So you guys can just interrupt with questions as they come up.
Sounds good.
Great. So really quick, let me just introduce my colleagues and we'll get started. I have Dr. Jennifer Piccolo. She is a clinical pharmacy specialist in cancer and oncology and also research at the Madison VA and formerly of UW Hospital, right, Jane? Yeah. And so she has been very involved in a lot of patient education and outreach, and he's got a particular interest in helping people make good decisions about this in the cancer space. I also have Dr. Ashley Hicks, who is another cancer specialist at UW Hospital, but now has moved into informatics And she also is very, very concerned and interested in patient safety issues. And again, helping patients make really good decisions about a variety of things. So they're going to be our pharmacist experts that are on the panel tonight. And then someone who are regular participants in VMU should recognize Dr. Elizabeth Felton, who's an assistant professor of neurology at UW. And Elizabeth does, well, she does everything fabulously, but you probably heard her talk about women's issues in epilepsy as well as the ketogenic diet. I have had her speak with my classes and other people's on health disparities and a variety of things. And I'm just really in awe that I have this great group of people here tonight. So with that, I want to get this conversation started. So Elizabeth, I'm going to throw the first sort of discussion point. And by the way, the rules of the road here, colleagues, is everybody jump in. If you want to, chime in or elaborate and contradict, argue, let's make it good TV. Elizabeth, tell me what we know about COVID and epilepsy. I mean, what do we know about the impacts of this virus on seizure disorders? Does it affect control? Does it make it worse? Tell me more.
Yeah, so it's a question that I get a lot, or I have received a lot over the past year. So in terms of people with epilepsy getting COVID, people with epilepsy are not necessarily at any greater risk than the general population at getting COVID. There are a couple exceptions to that. That would be if a patient with epilepsy has another medical condition that might put them at risk, that might lower their immune system or something like that, or if they're taking certain medications that could similarly lower their immune system. So actually getting COVID, people with epilepsy have just as much of chances as anybody else. But something to be mindful of is that many people with epilepsy have triggers for their seizures, which include illness and fever and any type of illness. Getting a cold, getting the flu, getting a GI bug, and getting COVID can lower seizure threshold. And many people with COVID get extremely sick where they have difficulty taking their medications and things like that. So again, if you're super sick, your seizure threshold is lowered. If you're having trouble keeping down your medications or taking your medications, again, that can lower the seizure threshold and lead to an increase in seizures. And so that's something that I've seen in several of my patients over the past year who have had COVID.
So let me ask you a follow-up on that, because I know I've been reading some of the papers too, and I think you're probably looking at this maybe more in depth than I am. So do we have any evidence that the COVID can trigger new seizures or potentially cause, in absence, say, of having a fever, can it cause new onset of epilepsy or seizures in people who've never had them before? And is it a risk for status epilepticus?
Yeah, so definitely people that don't have a prior diagnosis of epilepsy or seizures can develop seizures in the setting of having COVID. So many patients who've been hospitalized for COVID have been in the ICU, who've been in sort of a delirious state, have had EEGs over the past year, and some of them have had seizures. And so not necessarily a high percentage, but some have. And then people who have already a diagnosis of epilepsy can certainly have seizures and even status epilepticus, which are difficult to control or stop seizures as well. And that's, kind of in the acute phase of infection. There are many other neurologic symptoms that people can have, both in that sort of initial state, having encephalopathy, loss of taste and smell. Encephalopathy, when I say that, I mean just sort of, being in a state of confusion. Headaches, symptoms like that, but then there can also be some longer standing issues as well.
Okay, let's get back to those long haul things, because I think we'll get that in a few minutes, because I think that's really important. My own personal belief when I counsel patients when they're trying to make that decision is what this virus, even if you recover, quote unquote, it may be with you, for who knows, maybe forever. So let's move on now. I really want to now start talking about the vaccines. So Ashley, it's okay. I'm going to sort of, throw the first one at you, but everybody else, again, feel free to jump in here. So we've got 3 vaccines that are on the market right now, that are FDA approved right now. What are the differences between? Can you maybe you guys lead us through a discussion of how these medicines work?
Yeah, absolutely. So yes, as you mentioned, there are 3 vaccines currently in circulation. I'll kind of group them together based on how they work. So the Moderna and the Pfizer vaccines are what we call the mRNA vaccines. And so these vaccines, you need 2 doses. The Moderna is given 1 dose followed by a second dose 4 weeks later, and the Pfizer is given the first dose with the second dose 3 weeks later. And so again, these are the mRNA vaccines, which the way this works is that the vaccine delivers mRNA into the body. And so think about mRNA as code. And so this code goes into your cells and it basically tells your body to make a protein. And this protein resembles those little spikes that you see on the images all over the news and all the graphics of that COVID vaccine. So your body's actually making that protein. And then what it does is it shows that protein off in your body, and your immune system then recognizes that and says, hey, that doesn't belong here. It mounts an immune response and creates antibodies that effectively give your immune system a memory, so that the next time it sees that same protein, which could be an actual COVID viral infection, it's going to react, your immune system is going to react more quickly and be able to protect you against that. So those are the mRNA vaccines. The other one, the Johnson & Johnson vaccine, which is just a single dose, the way that works, it's similar but different in that the way that the mRNA gets into, or the way that the code essentially gets into the cell is in a inactive or neutralized kind of viral coding. So think about it like a Trojan horse sneaking the code into the cells. And then again, your own cells create the protein that then is presented to the immune system that gives you those antibodies to protect you against any future exposure to an actual virus. So in both ways, the vaccines are leveraging the natural power of your immune system. And it does take a couple of weeks for that effect to take in, for that body to mount that response. And so that's why there are rules about, how long we say you have to wait until you're actually protected from the vaccines.
So let me follow up on that. So first of all, is it fair to call these mRNA things? Is it fair to call them gene therapy?
No, absolutely not. So the way that these vaccines work, they do not interact with the nucleus of your cell. So the nucleus of the cell is the very, very center of your cell where your DNA lives. And so these vaccines don't interact with that, and in no way do they impact your DNA at all.
So good. So it doesn't mean that, that we're going to worry about, passing some genetic thing on.
Absolutely not. No. Yeah. And in fact, after that vaccine, the mRNA enters the cells and tells your cells to make that protein, it quickly goes away. And it's fairly fragile. And I mention that because that's important in terms of some of the storage and logistics that go along with the vaccines as well.
Sure. Okay, thanks. We'll get back to some other efficacy things. So Jenny, I'm going to put you on the spot. So help me out, sort of sorting through. Because I think a lot of patients, a lot of us, right? We're trying to make some decisions, and you're reading all these things about side effects of these vaccines. So maybe we start with like sort of the big picture, and tell me what the side effects I should expect. And then we'll talk about the individual, if that's okay. So big picture first.
Absolutely. So the side effects that you can see from the vaccines, they're very similar amongst all 3 of them. And it's similar to other vaccines like if you've ever received a flu vaccine, for example. So the very common ones that almost everybody could probably say they've had at some point with either a flu vaccine or another vaccine would be things like a little bit of soreness and pain at the injection site. I know that's where mine was, a day or two after, and that could even last like 2 to 3 days up to even a week, depending on how much you move your arm, et cetera. So that's a fairly common one. Sometimes it might be a little bit red, or you might notice that it's a little bit swollen, particularly for the ones where you get 2 doses of the vaccine. You might notice that a little bit more with that second dose because your immune system's ready and it's reacting right away. Other things that people can notice are kind of what we describe as flu-like symptoms. So things like being very, very tired throughout the day or a day or two afterwards. Occasionally people can get fevers afterwards, things like headaches, muscle aches, chills, and kind of those same sort of symptoms that you would get if you got the flu or another virus. The good part with vaccines is that should only last for, again, only a few days. And it's not because there's actually an infection. It's because your immune system's actually doing what it's supposed to do and it's reacting, and it thinks there's an infection. So it's going all out. And then after a day or two, when it realizes that it was a false alarm, things kind of die down and you should feel back to your normal.
Okay, before I get back to my second part, so Dr. Felton, so I know I've had this discussion with a lot of people, and I don't know that we have the right answer to this. I actually was on a CDC call with Tony Fauci about 3 months ago, and I tried to sneak my question in and never got to it. So I'm going to ask you. You're the next best thing we have to Tony Fauci here today. So with these flu-like symptoms, that people can feel. Are you telling your patients to treat it with things like ibuprofen or Tylenol? Are you telling them to treat or not to treat? And what are you telling them to do?
I'm telling them not to treat prophylactically or in advance, like not to start it before getting the vaccine. But if after the vaccine they have symptoms, that I'm telling my patients that they can take something for it, particularly if they have develop a fever. But not to just sort of like in advance or just in case. That's the guidance.
Okay, so you're telling them in particular, if they do, because of the risk of seizures, also with fevers, if they get a temperature?
Particularly if they are susceptible to that. So, some of my patients know if I have a fever or, that I'm more likely to have a seizure, particularly in those patients. I recommend that.
Okay, thank you. So Jenny, let's go back on to more of these. So we talked about the general side effects. What are the other things? What are some of the differences? Are there differences between the different shots of what you might get? And then let's talk about the thing I guess where everybody's on a lot of people's minds right now is the reports that we heard about the J&J vaccine. So I'll let you and Ashley, you guys can both jump in here.
Absolutely.
Yes.
So for the main side effects, the kind of things that I've already listed, they're very similar amongst the different shots. Overall, J&J seems to have the lowest amount of those types of side effects, where so fever is a little bit more common in like the Moderna and the Pfizer vaccine. And then with the Moderna and the Pfizer vaccine, it's also been noticed that the older you are, typically the less likely you are to have side effects. So for Pfizer, they noticed that people who were over 55 had less chance of getting some of these side effects, especially the things like the fevers and headaches, et cetera. And for Moderna, it was over 65, where they noticed that there was a little bit of a difference in terms of those patients having less side effects. So overall, though, the side effects are pretty comparable. So it's about 50% of people who would get things like the injection site pain. For the headaches, it's somewhere between 30 to 50, depending on the vaccine, but they're fairly comparable in terms of the side effects. As far as the clot risk with the J&J vaccine, which is absolutely the one that I think everybody's the most concerned about and the most aware of right now. Something that I think I just want to make sure to point out is I think that it's really been very good that they pulled the J&J vaccine like they did. Basically what they did is they saw this crazy syndrome where people were having blood clots, but then also having lower platelets. So they also had a risk of bleeding. And typically if we treat a blood clot, we want to treat it with a blood thinner. So that was where we were running into a lot of issues where if you're both having clotting and then bleeding, it makes it a little bit more difficult to treat because the treatments for clotting typically can cause some bleeding. So that's where we got into a little bit of a sticky situation with it. So they saw this kind of happening and they pulled the vaccine right away. And the reason they did that is they wanted to make sure that they weren't missing any cases. So they wanted to make sure that they saw these few people who were having it, but they wanted to make sure that there wasn't a whole bunch of people who were also having this that they just weren't aware of and just weren't getting reported. So really all that's actually showing to me is that the system's working how it should be. And it's really ensuring that these vaccines are going to be as safe as any other medication that comes to market, even though they were approved a little bit more quickly. With regards to the blood clots, when they looked at the patients, there was only 15 people that they saw who had this, and there was about 8 million of the J&J vaccine that was given. So it's only 15 people out of that entire 8 million people. And in the people who did get these blood clots, it was all women, and it was between the ages of 18 to 49. So if you look at those women, it was about 7 in a million people would be more likely to get that clot. The highest risk was between the ages of 30 and 39. And for that, it was 11 in a million people. Thinking about that and putting it into a little bit of perspective, if you were to get COVID, the COVID-19 virus actually also has a risk of causing blood clots for people. And the risk for that is actually quite a bit higher. So the risk for having blood clots with the COVID-19 infection is actually about 20%. So if we looked at that same 1 million people, that's about 200,000 people who could be getting blood clots from COVID. So when they looked through all this information, they really felt that the risk of getting the blood clots with the J&J vaccine still was not as bad as the risk of getting COVID, and the benefits still really outweighed that risk. So what ended up happening is they allowed it to come back to market, and it just has a little bit more of a warning on it. Okay. As far as the J&J vaccine, though, we do know that that's the only one that has the one injection. So that might be really a better option for a number of different people. So the kinds of people that I think might be better off with the one injection are if you're really afraid of needles and the thought of getting a vaccine already makes you really anxious, having just one shot and getting it done with, that might be really worth it, particularly knowing that you're going to get that protection from COVID afterwards. Another situation that it might be better to just have one vaccine is if, say you live really far away from healthcare and it's very difficult for you to travel and to get the injection. I wouldn't want it to be where you only can get the first dose of either the Pfizer or Moderna and then struggle to make it for that appointment to get that second dose, because then we don't really know how protected you are if you only get half of the vaccine. So for those people who have trouble either traveling or difficulty getting to healthcare, getting to a place where they could do the vaccine, one dose might be really a lot better for that type of a person as well. And really overall, I think getting the COVID vaccine is important. And that protection, regardless of which of the vaccines you end up getting, is going to be very important. And so certainly know that there are other ones out there. If you're a woman who falls into that age range and you are nervous about the blood clots, there certainly is availability with the Pfizer and the Moderna vaccine. And if that's important to you, you can certainly, you can always ask when you make your appointment, say, which vaccine am I getting? And they'll tell you. No one's gonna give you the song and dance, and you can absolutely be honest and say, I'm a little bit nervous about J&J. I want to get the other ones. And they'll be able to make those appointments and figure it out so that it works for you. So I think just knowing what's there and knowing the information about it is the important part.
Yeah, I agree. And, I think the other thing, there are some, and I don't know if anybody else wants to comment on this, if you've seen anything when you've been doing vaccinating, but there are the other differences, maybe when someone makes a choice. Well, actually, I'm going to hold off on my comments. I want to get back. I want to ask Ashley a question here real quick. So what we've just been talking about, you've got your choice. Does it really make a difference, other than if you don't like needles and the one shot versus, no shots or whatever? But in terms of what I can expect, or our patients with epilepsy can expect, no matter what age they're in, is there really a material difference in how well they work?
I mean,
and what are the variants? What about these variants we keep
Sure. Excellent question. So yes, all of the vaccines that are available have performed extremely well in terms of the studies that showed how effective they were in preventing a COVID vaccine, a COVID viral infection. The Pfizer and Moderna were in the 90% range. The J&J was in the 70 to 85% range, depending on if you're looking at standard infections versus, I think what we really care about is the severe infections that could end somebody up in the hospital or worse. And so, thinking about it like that, all of the vaccines performed extremely well. So I would say, as Jenny mentioned, if you're concerned about the J&J and you fall in that special population, I think you're very well entitled to seek out one of the other options. But I think, again, what's important is to get vaccinated because, speaking about the variants, so if you're like me and you get alerts on your phone from, the news station or whatnot, you've probably seen the UK variant or the South African variant and comments about its presence in our state. And so basically what we know is that it looks like the vaccines do protect us against those variants. However, the longer the vaccine the longer the virus is in circulation and the longer there are unprotected hosts, meaning unvaccinated people that this virus can jump to, the more variants there could be. And my concern with that is, when a variant comes around that the vaccines that we currently have don't protect against, and then are we, having to kind of start over. And so I think, to that point, really getting as many people vaccinated as possible is critical now that the vaccine's available to, everyone 16 years of age and older. And so I think that's really the most important thing to drive home here.
Okay, thank you.
Can I just add to that?
Yeah.
Something else that I think is kind of important to know is when they were looking at these vaccines, they did mark a point where they said, we want them to be at least this effective. And that point was 50%. And all three of these vaccines are above and beyond that. And then also, I think it always helps me to have kind of a little bit of perspective. And so an example, I know the flu vaccine is probably the most common vaccine everybody hears every year. Everybody gets reminded to get a flu shot. Those are typically only about 30 to 60% effective if you think of the percentages. So if you think about this common vaccine that everybody gets and nobody really, I don't even question it anymore. It's just like, oh, time for my flu vaccine. And I could be getting that and it only might be 30% effective. And then, these three different options are all going to be way above and beyond that. So really just keeping that in mind that these are all very protective against COVID infection.
Excellent point. So Dr. Felton, I want to ask you two questions. One of which real quick, is there anything that you've read or you've seen in talking to your neurologist colleagues, any evidence that the vaccine can trigger seizures as one of these side effects we've been hearing about?
No.
Good, I'm glad to hear you say that's what I read on it, but I'm going to the expert here. So the other thing, we've been talking about populations that people has been studied. One of the concerns I've heard from some of our patients, especially patients of color, is that they felt like they were not really represented in the studies. And is it reasonable to take these studies that were done in specific populations, say predominantly white populations, and is that fair, legit? Can you comment on that, on the health disparities in the studies?
Yeah, so COVID-19 has absolutely shown a light on the problem of health disparities, in the United States and around the world. So there is no denying that there are major problems with health disparities and major problems with, things like medical experimentation and things like that in vulnerable and underrepresented groups in the past. What good has come out of it is that it has shown a bright light on that. And there's a lot of people are doing to try to change that now. And so one of the things, and this isn't necessarily new with COVID, but, trying to increase representation of people from a variety of groups, particularly underrepresented groups within clinical trials. So, historically, these groups are not adequately represented. And so the vaccine companies were charged with really trying to make sure that their people that they were enrolling in their studies were diverse. And I mean, I know, UW was a site for one of the vaccine manufacturers, and I know that they were trying to get a diverse group enrolled. I did pull up today the statistics from the companies, and I'll just give an example. So, in the United States population, they're of age 16 and up, about 12.3% are Black. In the Pfizer trial, there were 9.8% Black, and Moderna was 9.7%. I have J&J here separately. J&J was 13%. So I felt that is not perfect, but it's not bad. So it was a little less for two of the companies than the general population of Black people in the US, but I think that they did make a lot of efforts to that. And they did not see that there was any difference in efficacy of the vaccine in those groups. But what we have seen is that some of those groups are disproportionately affected by COVID for a variety of reasons. And so it's another reason for everyone, but especially underrepresented groups, to get the vaccine.
Okay, so since you have those statistics, Andy, and I thank you for sharing that, because I actually didn't know those percentages. Do you happen to know what percent were Hispanic in the studies?
Yep. So for the US population, it's 17.6% Hispanic. For Pfizer, 26.2%. Moderna was 20%, so they got more, and J&J was 15%.
That is really important to know. Thank you for sharing that, because I think, a lot of us, I've done 2 vaccination clinics now, and I've gotten in some underserved areas, and people say, well, you guys are experimenting, and we, never tested it, in us, and my bad, I didn't have those numbers at my fingertips, but now I do. Thanks to you. So let me ask you questions. We're talking about safety, and I also want to, leave us time if there's people in the audience who do have questions. So one of the other questions and concerns that comes up is, gee, this stuff is not really FDA approved. And I'll just throw this to whoever in the panel wants to address this. What is the differences between this emergency use authorization and full FDA approval? What does it tell us? What does it not tell us? What does it mean? Anybody? I'll let whoever wants to jump in here. Or do I have to call in?
I can jump in. Shy. I was waiting to see if Ashley would unmute, but so what these are circulating under is called an emergency use authorization. So basically, the government decided, and appropriately so, that this was an emergency. This is clearly something we've never experienced before, hopefully something we don't have to ever experience again, where we're going through this global pandemic. And for the way that the difference in how they're approved, a normal medication, when it's going through clinical trials, it goes through a number of different phases. So the very first phase is usually healthy people, and they're looking at the safety in someone who's totally healthy, and making sure that it's a safe medication for them. The second phase would be where they're looking at a specific population. So maybe they're looking at cancer patients or epilepsy patients, or in this case, patients with the COVID vaccine, or the COVID infection rather, and looking at, is it effective, or is it safe rather, in those patients? And then your third phase is where you actually look at how effective it is. For an emergency use authorization, the safety phases do not change. So they still did the full safety testing for phase 1 trials. They did the full safety testing for phase 2 trials. And then the efficacy testing, that's the difference. So where a normal medication would have to go through a full phase 3 trial, have completely finished it and released all of the data at the end, when it's an emergency use authorization, they pick a predefined point. So this is where I got that number where they said we need it to be at least 50% effective, and it needed to be a certain time frame, which I'm not remembering the exact time frame it needed to be from the start of the trial, but there was a particular time frame they had to reach, and then a particular effectiveness that they had to reach before they could even submit for this. As we mentioned, all 3 of these vaccines are incredibly effective, and so they all reached that point. But the difference is that they were able to submit that submit the request for that authorization before the clinical trials are completely over. So there are still people who are technically enrolled on these phase 3 trials that are still being observed. They're still collecting the data in terms of more longer term infection risk, et cetera. And that's really the only difference in terms of the approval. So it's just that they were able to submit earlier for the effectiveness.
Yeah. Sorry, I think my connection dropped a little during that question. So thanks, Jenny. But I guess I'll just chime in and say too that I think it's worth mentioning that this is a global pandemic, and there have been huge number of resources that have gone into supporting these manufacturers' research and development. And so because we've had such cooperation between the government, the manufacturers, I think that too speaks to why the research has been able to be done, and the risk for the manufacturers is lower when they have the full support of the country, and there's global eyes on things as it is with this. Okay,
thank you. Yeah, so that was good. That was my understanding as well. I think that's important for people to understand. We're used to hearing about things that are FDA approved, but it's really, we're really now concerned not with the safety. We know, and from all the data that I have seen, that there's not been a single vaccine that's ever been studied that you didn't pretty much have a complete safety profile by 2 months. Side effects show up. This isn't like a chronic. Dr. Felton and I know, and I'm sure you guys know from my cancer, but we know some of our medicines we use to treat seizures, they can develop long-term side effects. Vaccines don't do that. If you get a side effect, you're going to get it within 2 months. So it's really, all we're really waiting to see now is how long it's going to be before we need to get our booster.
Right. Exactly. Exactly. Go ahead.
I saw a question that came up about side effects, and I could only, again, partially read it, but I'll let whoever wants to address this, that this idea that your side effects you get from the shot may be worse if you've recently had a COVID infection. Anybody want to tackle that one?
Sure. It is recommended that if you have gotten the COVID virus, or if you've received convalescent plasma or something to treat the COVID virus, that you do wait at least 90 days before getting the COVID vaccine. And that is because you are likely to have a little bit more reaction in terms of the fevers and the side effects that can come along with it. And part of that is because your body already has identified that you had this virus, and it already knows that it's foreign. So whereas whereas your body normally will have to prime, recognize it as foreign when you first get the vaccine and then respond to it, your body is ready to respond. So that's why it's just that much sooner. And so like with the Pfizer and the Moderna, you do see more reactions with that second shot because your body is more prepared at that point to respond. If you've already had the COVID virus, you've already basically had the pre-shot. So your body's already ready to respond even with that first injection.
Well, yeah, and it may very well be that if you've had COVID and you get the second, go through the whole series and get the second shot, you may even have a greater level of protection against reinfection. So,
possible.
Because I want to get to, because again, I'm really bad at being able to read questions that get submitted here. So I want to maybe have John come on in a couple of moments, but I want to circle back to where we started. I want to ask, we talked about epilepsy. We talked about COVID and what it can do in terms of seizures and neurologic issues. What about these long haulers, as they've been termed, and the neurologic problems? Dr. Felton, can you maybe just touch on that?
Sure. So this is still an active area, now that we are a year out, sort of understanding these long haul symptoms, which are basically where, typically you have a virus, you're sick, for a week or so, and then you're kind of better after that. But what we're finding with COVID is that some people have symptoms months, and I guess we're at about a year later, and still having lingering symptoms. And those can be symptoms that affect various body symptoms. Because I'm a neurologist, I'm kind of hearing about the neurologic complications of COVID that can be long-term. It's to the point where at UW, our neurology department has actually started a COVID clinic for these people that have these post-COVID symptoms lasting a long time later. And it's with one of our general neurologists and a neuropsychologist, because some of the symptoms that people often have are this like brain fog and cognitive symptoms that last for a long time. And, you know, just people not being able to really kind of get back into their normal routines, get back to work. And so being able to assess that. So, I mean, these kind of symptoms can really be quite lead to a lot of reduction in quality of life, you know, and lead to a lot of impairment months later, you know, headaches, you know, sometimes the sense of smell. We always hear about kind of one of the first symptoms people often have is this loss of sense of smell. Some people still have that months later, and that can be really make it difficult with eating and things like that if you lose that sense of smell. So there are a lot of lingering symptoms that can persist after COVID. So another reason to get the vaccine.
I just saw an abstract presented at the American Academy of Neurology, and I'm somewhere in Europe, and I can't tell you where, or maybe it was Canada, one of those places, that looked at healthcare providers who had COVID and found that the loss of taste and smell, there's almost 30% of those patients, it was out 90 days after infection, still had it. So it could be a long thing. So the one last thing, so we wrap it up and then ask for, and I know we've got some other questions that came in. So is the group's consensus here is that the shots are pretty much equal and safe and effective as far as we know in our patients with epilepsy? I'm seeing lots of
Yes,
Yes.
definitely.
Yeah.
I think the one other thing that I would tell patients out there, the thing that we haven't touched on, there one subtle difference, but it could be important, is the Pfizer and the Moderna, just because the way they're made, they have polyethylene glycol. So some people do have an allergy to that. That would be a thing to talk to your provider about, or if you go to a vaccination clinic, that where you might want the J&J. In fact, I would say you should get the J&J. So with that, folks, team, I just want to thank you guys a lot. Are there sort of closing comments before I ask John if we could open this up, and maybe again he could tell us questions we did not get to? Or any other closing thoughts?
I just had one other comment. The vaccine is approved now through down to age 16. And so, some of the people I don't know on the call might be parents of children under age 16. And so I would encourage parents, caregivers to get vaccinated in order to protect the younger children or people that can't get the vaccine for other medical reasons. And so that's, even if you feel yourself that you're not, for whatever reason, at greater risk, just to do it to help protect other people. And the other comment that I had is that I've just been amazed at how available the vaccine is now. I saw that here in Madison, the Alliant Energy Center, you can walk in now. You don't even have to have an appointment. And so you really can, just this privilege that we have here, that we can just get it now. And so I would just encourage people to do so.
And I would say there's all sorts of clinics that, same thing now. Let's say depending, at least here in Madison, if people live here in Madison on May 8th and May 15th, if you look on the Boys and Girls Club website, we're going to have additional clinics at Taft Street and on the Allied Drive location. But you're right, they're all over the place. So go get them. Dr. Hicks, Dr. Piccolo, any last comments before I open it up to our audience?
I echo the same, that I think when the pandemic started, we were all hopeful for a vaccine. And I think it's been really amazing to see the research and the healthcare community come together and really, offer up 3 really great options. So go get vaccinated.
Science works.
Yeah.
So, John, are there other questions that we did not address that you're seeing?
Yes, there are.
Well, outstanding. Let's hear them.
Let me also echo you by saying thank you to all 4 of you. That's terrific. Wonderful. So, first question: do seizures cause a lower or higher risk of severity with COVID-19?
Dr. Felton?
Yeah, so having a diagnosis of epilepsy or seizures does not increase your chance of getting COVID or having a more severe course with COVID. As we were talking about earlier, sometimes if infection or fever is a particular trigger, it could cause people to have breakthrough seizures. But aside from that, the COVID course is not necessarily different for people with epilepsy.
Thank you.
Okay, another one here. You spoke earlier about spiked balls, picture of spiked balls. Number one, are those proteins? Number two, is the protein the same thing as a virus?
Yeah, so when we were talking about the mRNA code that basically tells your cells how to make that protein. So yes, the protein that I was talking about, it does look like the spike on the virus, which is a protein itself. And so yes, the mRNA vaccine does tell your cells how to make that protein, which again kind of tricks your body into thinking it's fighting an infection, when really the whole point is so that it gives you the tools in your immune system, the memory to fight that infection more quickly. If the virus is actually entering your body. And what was the second part of that question?
Is a protein the same thing as a virus? That's what the person was asking.
Well, I guess the protein that we're talking about is the spike that the protein that your body mimics, and it looks like the spike that's on the virus, if that makes sense.
The protein itself is not a virus though. So you can have a number of proteins in your body, and those are not, that is not viral, and that is not going to cause an infection or anything like that. It's just looks similar to the protein that's on the virus. So your body can recognize it as being foreign and not being part of your normal system.
Right, it's that, so I think it's important for people to understand how all vaccines that you've ever taken work. Sometimes we use a killed version of the virus, and that's not what this is. None of them do that. Other vaccines take sort of components or part of that virus or a bacterium even, and again, it's making the body react to something. So that's really, it's kind of a new technology. It's just a new way of doing a very old thing that we've been doing for well over a century or longer, a couple centuries. So it's just a new way of doing it. So the vaccine do not create a virus. It doesn't give you COVID. It won't give you a virus. That's an important point. I'm glad somebody asked that question. Good question.
A way that I've explained it to patients is like, it's when you get that mRNA from the vaccine, basically, it's almost like if you took an instruction booklet where there's 3 or 4 pages of instruction and only ripped out 1 page to make this. You might be able to make a portion of whatever the end result is, but you're not going to be able to make the whole desk or whatever else you're assembling. You only have like maybe a drawer. So that's kind of what this is, where it's only making a portion of something that is recognizable on the virus, but it's not able to make the entire virus, and it's not able to then infect you or anything like that. It just allows your body to say, hey, that doesn't belong here. And so when that happens again, and if it sees anything else similar like that, it'll react and it'll be able to respond faster.
Except in my case, I don't always read all the pages of the instructions. It explains a lot of problems I have. John, other questions?
Yes. Is there a chance of a booster shot after Moderna, Pfizer, and Johnson & Johnson?
I would plan on it. I believe so. I think this is my belief. But I know that Moderna and I believe Pfizer is already working on one. I think this is going to be like our flu shot for a while, and what will help to keep us from having to do this, if we all get vaccinated and this bug goes away, like we all don't get boosters of smallpox or polio, because it's eradicated. If we all do that, but I think this is my opinion, I'm planning on probably getting an annual booster. I don't know what other people on the panel think.
I would agree with that. Part of the reason where we don't know exactly when or whatever, that's because because these were approved a little bit faster. So we don't know if we're going to have 3 months of immunity, 6 months of immunity, 3 years of immunity. And that's the part that we're still trying to sort of figure out. But like you said, I also heard that Pfizer and Moderna are kind of working already on a booster for the eventuality of when it eventually happens, they'll be ready for it. So I would also plan to eventually get one. We just don't know exactly when yet.
Okay. Can a sinus infection decrease the efficacy of any of the vaccines?
Who wants to take that one on? I think you're.
Yeah. I mean, I guess I would say no, a sinus infection would not decrease the efficacy. However, I think depending on how sick you are, it might make sense to hold off on scheduling a vaccine until you're feeling a little bit better. But it should not decrease the efficacy of the vaccine. That, of course, is not a special case that's been studied necessarily, but thinking about the mechanism and things like that, I would say that does not decrease the efficacy.
Right, and as far as I know, and this would go for most all vaccines, you know, antibiotics are not going to affect.
Right.
You're taking an antibiotic for an infection of some sort. And I would also say, as far as we know, none of our anti-seizure medications should interfere with how the vaccine works.
Right.
Important question. Glad somebody asked that.
On the Walgreens survey, I was asked if I had previously ever had a seizure. I'm assuming the person is asking, is this something to be concerned about? She or he stressed that the neurologist had approved the shot for this person.
Elizabeth?
Oh, go ahead.
No, I'm calling. Can you want to address that?
Oh, yeah, I saw that question in the chat as well. I was surprised by that. I haven't had other people report that. And so it sounds like that might have been an isolated piece of misinformation that individual was told. You know, history of seizure or epilepsy is certainly not a contraindication to the vaccine. And I'm glad that the person who posted the question told them that their neurologist approved it. So I am not sure why that happened.
Yeah, I'm surprised too of all the vaccination clinics that I've participated in, and I know what the standard, you know, CDC recommended screening questions are and warnings. That is not one of them. So I don't know. Maybe they were just collecting general medical information. I'm unclear, but there is no concern about that.
Let me just piggyback on that one asked for myself, is if somebody is a neurology patient, should they be discussing this with their neurologist first?
That's a great question. I think if you have any concern about whether or not the vaccine is appropriate in your situation, then you should. I would say the majority of my patients, no, I wouldn't say the majority. I would say maybe half of them have asked me in advance, you know, should I get it, that kind of thing. And about half have just gotten it, you know. And so I think if there's just any question or concern, then you should talk to your neurologist. Certainly, if you're in a situation where you're taking a medication that might lower your immune system, or you're on a, you know, have medical conditions besides just epilepsy that you're concerned about, you know, either related to COVID or related to the vaccine, then definitely reach out to your neurologist. But I would say the majority of people that have a diagnosis of epilepsy without other medical issues and just go get the vaccine.
Agreed. When in doubt, go to your healthcare provider for the most reliable, up-to-date information.
Okay. That at this point is the end of the questions that I'm seeing. Alicia, are you seeing any?
Nope, John, you did all of them. Thank you.
Okay. Let me also say, if you are thinking of any questions after we're done tonight, please go ahead and submit them. I'll type the email in there again. Whoops, that's not going to work. Epilepsy, connected epilepsy Wisconsin .org. And if you think of something when we're done, please submit it. We will get it to one of our speakers tonight to get you an answer. And once again, as Alicia said, these videos will be up in our library sometime within a week or so. But that's the last of the questions I'm seeing. Anybody else wants to submit one in the next minute or so? But other than that.
All right, well, I'm going to take this opportunity. Thank, first of all, Alicia and John, thanks for all the technical and logistical support tonight. And to my colleagues, thank you so much again for sharing your time and talents, you know, and for the benefit of our patients with epilepsy, you know, throughout the state and beyond. So thank you so much. And with that, John, if we're not seeing any further questions.
Yes.
We'll
Great.
Conclude our program for tonight.
Thank you. We'll see you next week, everybody. Have a good night.
What's our next meetup, Alicia?
I don't have it in front of me.
Oh, well, in that case, I'm sorry. All
Sorry.
Or do I?
right, folks.
All right.
But always Thursdays at 7 o'clock. Always
Yes.
Thursdays at 7. So
Thank you so much to everybody.
Thank you. Have a good night.
good night.
Good night.